Hi everyone, thanks for attending this opioid epidemic webinar. Qualidigm, as the Community and Clinical Integration Program CCIP transformation vendor for the State Innovation Model Program Management Office, is pleased to have Dr. Craig Allen here with us today. Dr. Allen is the Medical Director of Rushford and is board certified in addiction medicine, general and child and adolescent psychiatry. He is on the State of Connecticut's Alcohol and Drug Policy Council Advisory Board for the Department of Mental Health and Addiction Services, and the President-elect of the Connecticut chapter of the American Society of Addiction Medicine. Dr. Allen is a member of the Medical Directors Institute of the National Council for Behavioral Health and has held the title of Clinical Instructor in Psychiatry at both Harvard and Yale Medical Schools. Currently, Dr. Allen trains psychiatry residents and child and adolescent psychiatry fellows from the Institute of Living and Addiction Psychiatry and teaches and advocates for prevention, screening, early intervention, and treatment access for substance abuse and other psychiatric disorders. Thanks for joining us all today. Dr. Allen, take it away.
Thank you. Thanks for the introduction, and thank you for joining in today. I'm going to be talking about the opioid epidemic, which is affecting Connecticut and all of the United States, but the Northeast is hit harder than many parts of the country. The first slide here is just illustrating the increased number of opioid-related deaths. This particular slide has to do with heroin and synthetic opioid deaths. You can see the dramatic increase across the country since the early 2000s. Oops, I clicked on the wrong one. There we go. The objectives today describe the scope of the opioid overdose epidemic, discuss factors leading to and driving the epidemic, and identify the physician's role in assessing and treating opioid use disorders and preventing opioid overdose deaths. I want to mention, if anyone has any questions, you can just type your questions in on the side as we go, and I'll try to answer them as long as it flows okay. So this is the scope of the problem. Yesterday, I was lucky enough to be at a roundtable discussion with Seema Verma. Seema Verma is the administrator for Medicaid and Medicare, and she was in Hartford. She's going across the country on this tour to hear from doctors. And there were a lot of different questions about quality measures and the overwhelming burden of paperwork. And I wanted to get a chance to say something. And I wanted to talk about addictions. I want to talk about behavioral health. And I eventually did. But I needed a really good catchphrase to get everybody's attention. And this would have been it if I remembered to say it, but I'm saying it here today. Drug overdose is the leading cause of death of Americans under the age of 50. And I think that says it requires our immediate attention. Relative to some other tragedies and catastrophes through the years, the numbers of overdose deaths now have reached and surpassed some of those unfortunate hallmarks. Close to 50,000 or more people will die from opioid-related overdose deaths in 2017. These numbers are from 2016, as you see in front of you. The annual overdose deaths from opioids exceeded traffic fatalities back in 2008 and have continued to separate. And those are all overdose deaths. A significant portion of the overdose deaths are opioid-related. And the majority of the opioid-related deaths still are related to opioid analgesics, such as the ones that are listed on the slide in front of you: methadone, hydrocodone, oxycodone products, Vicodin, Oxycontin. So a little background on opioids. Opioids bind to the mu receptors in the pain and reward pathways. Wow, I just lost, sorry about this. I lost my screen. Hold on a second, there we go. Okay. When the opioids bind in the pain pathway, and that's the green pathway on your slide, thalamus, brainstem, spinal cord, you get analgesia, so you get a decrease in pain. When they bind the reward pathways, and that's in the ventral tegmental area, nucleus accumbens, and parts of the cortex, people experience euphoria. They also experience a sense of well-being and connectedness, which can last for a number of hours. Tolerance develops. This is a state that occurs when higher and higher doses of the same drug are required to achieve the same effect. And this occurs both with pain and in the reward pathway, and also in the respiratory drive center in the brainstem. Dependence is a state in which normal function now starts to only occur in the presence of the drug, and one experiences a physical disturbance when the drug is removed. The physical disturbance is referred to as withdrawal, and with opioids, you get the classic symptoms of runny nose, nausea, vomiting, diarrhea. Some people describe it as the worst flu you could ever imagine. And one of the problems is that someone who's been using opioids knows exactly how to cure those symptoms, which is to use the drug again. An overdose occurs when the respiratory drive center is overwhelmed by opioids. And this is after a loss of tolerance. The respiratory drive center loses tolerance quicker than the pain pathways and the reward pathways. This overdose usually occurs after a period of abstinence, when someone returns to using the drug, often in the same amounts as in the past. This can be when someone gets out of a treatment program or out of incarceration or has just not used in a while. This can also occur when there's an abrupt increase in the amount of opioid being used or in the potency of the opioids being used. And this is something that we've been seeing a lot in that synthetic opioids, which can be 30 to 50 times more potent than other opioids such as heroin, are used on the street. This picture here comes from Volkow and Coombs, and you'll see this picture again later in another slide. It's a classic description of the addiction cycle in 3 phases. It looks at the anatomical parts of the brain, as well as the neurotransmitters and the pathways, the neurocircuitry that are involved with addiction. It starts with intense intoxication, which leads to the development of tolerance, using more and more of the substance to get the same experience, followed by withdrawal, which includes the physical symptoms noted in the last slide, as well as emotional and psychological symptoms such as irritability and depression. And that's coupled with intense cravings and preoccupation, which is experienced, driven partly by parts of the prefrontal cortex. This preoccupation leads to a loss of control over use. As use progresses, the opioid has to be taken to avoid the severe negative effects that occur. And people are no longer taking the drug to experience euphoria, but taking it so that they can try to feel normal. With repeated exposure to opioids, stimuli associated with the pleasant effects of the substance, places, persons, moods, paraphernalia, and with negative mental and physical effects of withdrawal, all can trigger intense cravings, preoccupation, and use. So people sometimes hear, and I've often heard that one of the patients I see will start craving an opioid or craving heroin after they experience flu, because it reminds them of the withdrawal symptoms, and their brain quickly connects to how they can solve this problem, such as using an opioid. This is a slide illustrating the difference between opioid dependence and opioid addiction. This comes from the Diagnostic Statistical Manual, Part 5, and it's for all substance use disorders. It's a continuum with increasing intensity, decreasing severity. There are 11 symptoms for any of the substances. So in this case, we'll be thinking about opioids. Goes from mild, having 2 or 3 symptoms, to moderate to severe. And these problems, this problematic pattern of use has to occur over the course of a year. You have to have at least 2 from one of the following categories to have a mild disorder. So we have impaired control, taking more for longer than intended to, unsuccessful efforts to stop, cravings for the substance, spending a great deal of time obtaining, using, and recovering, social impairment, risky use, recurrent use in hazardous situations, people that are at greatest risk to overdose and die from an opioid overdose are those who have overdosed in the past. And then pharmacologic dependence. We just discussed tolerance and withdrawal. Factors that are driving the epidemic include deficits in healthcare knowledge, deficits in training around appropriate treatment of pain, deficits in understanding around opioid medications, and lack of training about addictions. The availability of inexpensive and high-potency heroin, and now what has been flooding the Northeast, are even more potent and less expensive, illicitly made synthetic opioids such as fentanyl and fentanyl analogs. Rising numbers of people being addicted to opioids leads to people overdosing, and then the lack of treatment capacity for opioid use disorder. The slide here on the left illustrates prescribing patterns in the United States through the years, and you see that starting in the late 80s and really picking up in the mid-90s, healthcare providers, physicians were prescribing more and more opioid analgesic medications. And there are a number of different reasons that led to this, starting with questionable science, which was picked up by some of the national quality organizations, the American Pain Society, American Association of Pain Management, the Joint Commission, all started to highlight the need for pain management. However, most people were not trained in any other strategies than using opioid analgesics. At the same time, there was a very, very aggressive marketing strategy from companies such as Purdue Pharma and campaigns against opiophobia, saying that doctors were unreasonably afraid to prescribe these medications. And then there were standards put in place that where doctors were penalized for not addressing someone's pain, despite not having necessarily the tools. On the right-hand side here shows that as the opioid sales increased, there was a parallel increase in opioid overdose deaths and opioid treatment admissions. So the last slide we looked at on the left-hand side, that was measures of morphine milligram equivalents. So morphine milligram equivalents are the amount of morphine an opioid dose is equal to when it's prescribed. This can be used as a gauge of the abuse and overdose potential of the amount of opioid that is being given at a particular time. In the state of Connecticut, the prescription monitoring program, which all doctors have to check if they're giving more than 72 hours prescription of a controlled substance, sends out an alert if your patient is prescribed more than 90 morphine milligram equivalents per day. The slide on the left illustrates the risk of overdose with the morphine milligram equivalents per day. As you get to 90 morphine milligram equivalents per day, the risk of overdose doubles. And as you can see, when you go up near 100, it's 9 or 10 times greater likelihood of overdosing. So people on higher doses of opioids have a greater risk of overdosing. The Center for Disease Control and Prevention has guidelines for prescribing opioids for chronic pain, and I'd recommend you take a look at those. They're fairly simple, straightforward guidelines. There's some one-sheet educational pieces that might be helpful in your daily use. This slide here is illustrating what happens with the amount of opioid analgesics that's out in the community. There are a lot of people who become exposed to opioids. So non-medical prescription opioid use is associated with 70 to 80% of new heroin users. What that means is that it's not necessarily one's patient who you're prescribing the medication for that then misuses it or uses it in a non-medical way and then escalates to using heroin, but somebody is using those prescriptions that are in people's medicine cabinets or sitting on bedside tables or purposely being obtained and sold out on the streets. The slide shows that as the opioid analgesics doses, the amount out in the community is the way I think about it, goes up. Eventually, sometime around 2010, there was an escalation in the amount of heroin used. What happens with people who become addicted to opioids is that the doctor is not going to be prescribing them or can't prescribe them enough, and they get multiple doctors, but it's very expensive to use opioid analgesics on the street. It's like $1 per milligram. Heroin is much less expensive. So people can't get opioid analgesics from their doctors. They can turn to heroin, which will stop their withdrawal symptoms and can perpetuate their addiction. The slide at the right-hand part of the slide shows that beyond heroin, the illicitly made synthetic opioids, such as fentanyl and fentanyl analogs, have really taken hold, going from associated overdose deaths in the state of Connecticut in 2012, 14 associated deaths, to 2016, 479 associated illicitly made fentanyl deaths. The number of opioid overdose deaths from fentanyl has now surpassed the number of deaths occurring from the use of heroin. These red dots show deaths in the state of Connecticut, opioid-related overdose deaths. And in 2014, there were 504. 2015, there were 657. 2016, there were 832. And the first 6 months of 2017 came out. So this is an estimate, and unfortunately, it may even be higher. This is a range, but the number it'll probably be well over 1,000 in 2017. And for every opioid overdose death, there are 30 people who go to the emergency department. So who are these patients on high-dose opioids? Some of the people that die from opioid overdose have a substance use disorder and an addiction. Some don't have an addiction, and they're just taking the medication as prescribed. But as noted earlier, if they're on high doses, they're at increasingly higher risks of overdosing. It's important to keep in mind that simple tapering or abrupt discontinuation can lead to someone seeking the end to the withdrawal symptoms and to feed their habit by using illicit drugs. And this is an incredibly risky situation, even more so these days with the super potent synthetic fentanyl type drugs in the community. Simple tapering or abrupt discontinuation can lead to life-threatening withdrawal, especially in patients with medical and psychiatric comorbidity. Remember that along with the physical symptoms, there are the psychological symptoms of withdrawal, which can include depression and anxiety and irritability. Here's this picture's returning again, the Volkow and Krups diagram. And this is a diagram that was used in the Surgeon General's report, Facing Addiction in America. It's a report on alcohol, drugs, and health. It came out November 16, 2016. I'm going to guess if you are similar to every other audience I've spoken to over the last year, you haven't read this report, but it is an excellent report. It's available online. Your tax dollars paid for it. And Dr. Murthy was the Surgeon General. He has since been removed from his position, but this was his crowning achievement. My hope is, and I believe that as time goes on, more and more people become aware of this and avail themselves of it. It's easy to navigate. It starts at gives a very simple understanding of addiction, but it goes into as much depth as you want to go into. And so I think it's an excellent resource for education. One of the things that this report found was that, or highlighted, I should say, is that in the United States, although we are #1 in spending on healthcare in the world, #1, we have the number 27th life expectancy. And of all the developed countries in the world, we are the, I'll say the first one, certainly in recent history, for our life expectancy to flatline and not continue to rise. And in fact, there's a segment of our population which the life expectancy is actually decreased by a number of months, and those are middle-aged to middle-aged white males. And the reason for this has to do with substance use disorders and suicide. So what Murthy says in his report is there's a treatment gap. And it's that although we have treatments for substance use disorders, we have treatments for behavioral health disorders and for suicide, the treatment gap is the direct result of lack of access to affordable care, shame, discrimination, the absence of screening for substance misuse and substance disorders. So how do you identify drug use and addiction? Well, you got to ask about it. And when you ask about smoking cigarettes, ask about alcohol use, ask about using illicit drugs, ask about taking prescribed drugs in ways that were not on the prescription. Ask about past histories of addiction. People with a past history of addiction or a family history of addiction are at much greater risk of having or developing a substance use disorder. Ask about marital and family problems. Oftentimes, situations where there are domestic issues, there can be an underlying substance use disorder. Someone gets injured in the emergency room. What caused it? I always think about a story that this guy had broken his arm and he'd fallen off a ladder, and we were getting ready to had him all patched up and ready to walk out the door. And one of the nurses asked, "How did that happen again?" It turned out the guy was up on the ladder, but it was after drinking 12 beers. And so there was an opportunity to talk about substance use and whether he may be drinking too much and maybe needed some help. Traffic accidents, being locked up, these are all opportunities to ask a little bit more, probe a little bit deeper. There are screening tools that are available, some simple screening tools for alcohol and substance use disorders. This one listed here is a very simple, quick tool looking at during the last year, how many times have you had 5 or more drinks? You ask, how many have you ever had 5 or more drinks last year? And if you have, then you've screened in as having a significant increase in risk of having a substance use disorder. And similarly for drugs, have you ever used an illegal substance in the last year or used a prescription medication for non-medical reasons? The positive screen is 1. I want to mention that there's going to be the Community and Clinical Integration Program Learning Management System, which is behind this presentation today, has coming out self-guided presentations to help primary care providers and their staff better understand and screen for a number of different disorders, including depression, anxiety, trauma, alcohol, and substance use. And so you'll have the opportunity to get more information regarding these screens, which I think are essential in our practice. It's important to understand what addiction is, so you can differentiate it from dependence. The treatment of dependence isn't the same as the treatment of addiction. I saw a patient actually just a week or so ago who came to my office saying that they needed to be put on a medication for, and they needed to go on Suboxone. Suboxone is a medication that is only used for an opioid use disorder. It's illegal to use it for other reasons. And I asked why they wanted to be on Suboxone. They said that their primary care provider told them that they were on too high of a dose of opioid analgesic. I think they were on OxyContin, and or Vicodin it was. And when they tried to decrease it, they would start to feel sick. And so we talked a little bit more about it. And this is a case of dependence, which can occur with tolerance and is expected with opioid analgesics. The person had not exhibited any of the other symptoms of addiction, like we went through in the DSM-5 criteria. Therefore, what this person needed was to have their medication tapered to the lowest possible dose. The treatment of addiction requires more than prescribing of drugs. The treatment of, and we'll talk more about treatment as we go on. If you find that someone has a substance use disorder, it's important to be supportive and to check yourself as to whether or not you are being judgmental. And we'll talk more about this, but addiction is a chronic and recurring disease. Like other chronic diseases, people don't really have a choice whether or not they're going to become addicted. They have a choice of whether or not they ever will use an addictive substance when they start. But developmentally, 80% of high school seniors have used an addictive substance, so there's a developmental normalcy to using addictive substance. What they may not have control over is whether they use it again. Share what you know about addiction. Refer that person to a specialist for an assessment. Refer to mutual self-help groups. This is AA, NA, Al-Anon for families, and there are many other self-help groups out in the community. And if someone has a substance use disorder, avoid mood-altering substances. So benzodiazepines, many sleep medications, certainly opiates. And again, do not immediately taper or discontinue opioid analgesic medication. Something to be discussed and develop a plan. So how is addiction treated? Well, it can be presented as an acute problem, but if someone has a full-blown addiction is actually a chronic illness and a chronic disease. And we know there are different treatments for acute illnesses versus chronic illnesses. If someone has a strep throat, then they're treated with antibiotics for 2 weeks and they're better. If someone has diabetes, then they're educated about diet, exercise, potential medications that may be used, and the fact that this may be a lifelong challenge. The American Society of Addiction Medicine, this is a very brief synopsis of their definition. Primary, chronic, reoccurring disease of the brain involving neurocircuitry of memory, reward, motivation, and impulsivity. There are cycles of relapse and remission without treatment or engagement in recovery activities. These disorders are progressive and can result in disability or premature death. So when you treat someone for a chronic disease like hypertension, over on the left there's no treatment, you got high blood pressure. As you move across, you're providing treatment, you're providing an antihypertensive medication, and you have lower blood pressures. When the antihypertensive is gone, you have a return of high blood pressure. Maybe as high or maybe not quite as high as before, but certainly much higher than when someone is actively engaged in the treatment. And similarly, for substance use disorders, and this is looking at alcohol and looking at alcohol consumption, when treatment is ongoing, the amount of consumption either stops or decreases significantly. And when treatment ends, there is a rebound in symptoms and a rebound in alcohol consumption. So, similar to other chronic diseases, drug addiction has the same relapse rates compared to diabetes, hypertension, asthma. And these rates are similar in terms of adherence to medication or adherence to other parts of the treatment plan. So we often talk about someone ending up in the emergency room with an overdose from opioid analgesics. And I've heard before from some emergency personnel, they said, why do we bother to use naloxone here and revive them? They're just going to be coming in another week or another month with another overdose. And naloxone is not a treatment, but naloxone keeps someone alive. But you don't hear the similar complaint when someone comes in with a heart attack. The AED is used and they're cardioverted and they're alive and everybody's happy. People aren't saying, why do we bother even doing this? This person's going to go back out, eat pizza, not exercise, and not take care of themselves. So why do we even bother? We do it to give them an opportunity to get into treatment and to get into recovery, and we need to continue to work with these people to try and help motivate them and give them the resources that they need to be treated. So what's the goal of treatment? The goal of treatment is to decrease withdrawal symptoms, decrease cravings, decrease urges to use, and decrease the vulnerability of overdose, and decrease some of the comorbid physical problems that can occur, as well as the comorbid behaviors that can occur with someone who's developed a substance use disorder. We want to improve functioning of the prefrontal cortex, and we didn't get too far into talking about those schematas of Volkow and Kubes, but it is the prefrontal cortex that stops working very well, which is the brakes that people have, the decision-making apparatus, the suppressing apparatus that can overcome urges or cravings or desires and reason that this might not be a really good idea at this point in time. And that has to be exercised, and that has to be utilized in order for someone to get back into recovery. So we want to improve the function there. We want to improve access to alternative rewarding activities, and we want to have an upregulation of the D2 receptors. This is another area that we didn't talk too much about but that in part has to do with the prefrontal cortex as well. We want to improve someone's ability to manage stress, conflicts, and emotions, because one's ability to manage these situations may have been impaired before substance use disorder, but certainly are impaired once someone develops a substance use disorder. And overall, we want to improve health, relationships, work, and school performance. What are your treatment options for an opioid use disorder? There's the abstinence-based approach, which traditionally has been used, focuses on detox from the opioid that the person is addicted to, followed by psychosocial treatments, and no medications. And there used to be this idea that in Alcoholics Anonymous that any medication you were taking was a drug, and you weren't, they use the term clean, you weren't clean if you were using any kind of medications, and that used to apply to antidepressant medications, although I don't think it ever applied to antihypertensives. Medication-assisted treatment is the other alternative. That is using medication in addition to the psychosocial interventions. And just briefly, psychosocial interventions are therapy. And the goal of therapy is to modify addictive behaviors, partly to encourage engagement with psychopharmacology, to address psychiatric comorbidity, and to enhance the function of the prefrontal cortex and be able to manage cravings and urges. Medication-assisted treatment is the evidence-based, most effective and evidence-based intervention. It's the first-line treatment for opioid addiction, and it's recommended by these institutions listed on the right. Without medication-assisted treatment, so using an abstinence-based approach after detox, there's a 90% relapse rate if someone is not getting medication-assisted treatment along with psychosocial treatment. It's consistently more effective than treatment without medication in reducing relapse rate, overall deaths, public health costs. And it reduces opioid use, withdrawal, craving, and all the related morbidities and mortality. MAT includes 3 different FDA-approved medications, so any one of these 3 types of medications. Methadone, which is a full mu receptor agonist, that can only be obtained by going to a dispensary. And for the first 6 months of treatment, usually 3 to 6 months, involves Monday through Saturday coming to the clinic to be dosed while you're at the clinic. Buprenorphine, naloxone medications, of which Suboxone is one, and then these are the names of a couple of others, Zubsolv and Bunadil. That's a partial agonist on the mu receptor. So, like methadone, it will prevent withdrawal symptoms. It will prevent cravings and urges to use, but in that it is a partial agonist, it does not cause as much euphoria, and there is a ceiling effect on its respiratory suppression. So it's actually a safer medication to use. It has fewer interactions with other medications as well. Big concern with methadone is QTC interval, elongation of the QTC interval, and that does not appear to be an issue with buprenorphine-based medications. Now, both of those medications are considered opioid replacement therapies. The third medication, naltrexone, is not an opioid replacement therapy. It's sort of the opposite of that. It is a blocker. It blocks the mu receptor without activating the mu receptor. Although it appears to have some effect on decreasing cravings as well. It's not clear how that works because this does not directly activate the receptor. The challenge with naltrexone, which comes both in an oral form, Rivia, and the much preferred would be the injectable form, Vivitrol, is that someone cannot get on this medication until all of the opioids are off of their receptors. So that means maybe 7 to 14 days opioid-free before they can take this medication. And when someone is addicted to an opioid, being able to go without using for 7 to 14 days is very, very challenging unless they are in a structured environment like a residential setting. The process for a primary care provider: build trust and optimism, reach an agreement on incremental next steps, and ultimately therapeutic goals, develop a plan of care, and collaboratively determine the role of the primary care provider with the specialty treatment center or specialty clinician they may be working with. Primary care tasks can include initiating the medication. People, health providers, doctors, nurse practitioners, PAs can get a data waiver, which is after they complete a course, 24 hours for nurse practitioners and PAs, 8 hours for physicians. You can get a certificate that allows you to prescribe buprenorphine-based medications like Suboxone and Bunadil and Zubzol. So some practices will initiate the medication and maintain the medication in the office utilizing an outside specialist or specialty clinic to do the psychosocial treatment and maybe even help with some of the monitoring, such as urine toxicology screening. The primary care doc may be monitoring response to treatment. That involvement can be crucial. Some people get better just having, knowing their primary care is involved. Can also keep an eye out for adverse effects. Engaging and encouraging a positive view in treatment is essential. Understanding that treatment can be quite effective is essential, even if it's not being provided at the primary care office. Coordinating care provided coordinating care with parents, school personnel, maybe a medical home like we do here at Rushbridge for some of our severely mentally ill patients, and coordination with specialists. That can all be part of the primary care doctor's role. So I want to talk a little bit about naloxone. Naloxone is the opioid overdose reversal medication. It is a pure opioid antagonist, and it can save someone's life when administered to someone who has overdosed on opioids. It is not psychoactive. Like naltrexone, it blocks the receptor. Unlike naltrexone, it has a very short half-life. It does not have any abuse potential. It certainly would cause withdrawal symptoms because it knocks the opioids off the receptors. It can be administered in multiple different ways. It can act within a couple of minutes. Remember that it only lasts for 30 to 90 minutes, so someone can experience an overdose again once it wears off if the opioids are still in their system. And it's important to know that it may be repeated. This repeating of the administration of naloxone has occurred more frequently over the last year or so because of the increasing potency of some of the drugs, the opioids, the heroin and the fentanyl on the streets. Narcan equals naloxone. They're the same thing. Narcan is a name brand. Naloxone is not the same. This is stuff that you guys probably know, but it's helpful for some people to see that naloxone is not the same thing as Suboxone. Suboxone is buprenorphine plus naloxone. Naloxone is not the same thing as naltrexone. Naltrexone is sort of a long-acting form of naloxone. And who would benefit most from Narcan training and a prescription? So it's important not only that someone gets a prescription and then fills the prescription, but that they get education on how to use the medication. And educating that person doesn't necessarily help them if they were to overdose, so it's important to educate those around them if possible. But even educating the patient in front of you can be quite helpful, because oftentimes people who use are around other people who are using, and it can lead to someone else's life being saved. People that are being treated for opioid poisoning or intoxication in the emergency room, I believe they should all leave, not just with a prescription. If there was a way to do it, and I know there's always a way to do it, if people could leave with an opioid overdose kit in their hands and the very brief, simple education, which is available at a number of different websites on how to identify signs and symptoms of opioid overdose and how to use the medication. If people could leave the emergency room with that medication, I think it would have a significant impact on overdose deaths. I think anyone starting on methadone or buprenorphine therapy should have naltrexone. I think anyone that's prescribed opioid analgesics, but greater than 50 milligram morphine equivalents is a reasonable approach. Anyone being rotated between different opioid prescriptions, and anyone who's getting opioid prescriptions and takes a benzodiazepine, an antidepressant, or has another chronic medical illness. They're all at increased use, and certainly alcohol and opioids can lead to an overdose. This is some data that shows opioid overdose education and naloxone distributions in different communities. And this data, I think, was through 2014, and it shows over 150, well, the number is 26,000 overdose reversals as of July 2014. That number has certainly gone up. These are a number of different studies that support the efficacy. People worry that if you're going to give out naloxone, more people are going to go out there and use, but the studies show that that is not the case. What happens in communities where education and naloxone is provided is that the number of overdose deaths go down and the number of people entering into treatment goes up. This is rationale. These are a couple different types of naloxone deliverers, and here's the rationale. Most opioid users are not alone. The rationale for educating everybody. We know the risk factors. There's a brief opportunity, and sometimes people won't call the police because they're afraid to get in trouble. So if they had naloxone, maybe they could have saved someone's life. Although there are Good Samaritan laws in the state of Connecticut where if someone does call the police when someone's overdosed, they will not be arrested for having heroin on their person or in the area. Narcan only reverses the effects of opiates, so these are opiates. It doesn't reverse the effects of a benzodiazepine overdose or a cocaine overdose or an alcohol overdose. But you never know what someone got, so the first responders, who now in the state of Connecticut all carry naloxone, will provide it. So here's a summary, take-home points from today. It's important to identify and treat opioid use disorder. Addiction is a brain disease. There are treatments that work. FDA-approved medications to treat opioid use disorders include buprenorphine, naloxone, methadone, and naltrexone. They're most effective when combined with psychosocial treatment. Medication-assisted treatment should be long-term. There are no end dates for medication-assisted treatment. What the data does show is that when someone's on medication-assisted treatment, the risk of overdose, the risk of criminal behaviors, the risk of comorbid physical and infectious disease is decreased, and when they're not on it, those numbers are higher. Naloxone formulations are approved to treat opioid overdoses and save lives. In the state of Connecticut, pharmacists who are certified can give naloxone out without a doctor's order. I think it has extra cachet when your healthcare provider talks to you about the risks of an opioid overdose and provides the prescription. I think it has a greater impact on the patient and the patient's family. Treat your addicted patients with kindness and respect, understanding they are ill, just like cancer or diabetes. and get help with your addicted patients through specialty referral and collaboration. So if you guys have any questions, please feel free to ask. I guess there's one that I see up in the corner. What are the root causes of this epidemic? Is it hopelessness, depression, or other behavioral health issues? The answer is yes. That's the answer to that. What is the root cause? There's a very interesting, cool YouTube video, which I'm not going to remember the guy's name, but I can tell you how to find the YouTube video. It's called Addiction. If you go to YouTube, it's a cartoon, but it's a cartoon that's based off of a TED Talk. The author of the book, whose name's not coming to me, writes about experimentation. The video includes Rat Park, and the idea is that there is something that people are getting from opioids beyond being high, and the thought is it has something to do with that other part of that other thing people experience when they take opioids, that sense of connectedness, that sense of well-being. And the idea that our communities are less and less connected, less and less tied together, more and more siloed. You can't help but think that the smartphones and information technology and screen time may have something to do with this, as well as the hustle and the bustle and the emphasis on success, financial reward, and people are feeling less and less connected. And it appears as though endogenous endorphins and enkephalins, so endogenous opioids, or things that modulate the opioid system, are released when in different types of bonding situations and different situations where you are connected to a family and connected to a team or a group. The United States uses over 80% of all the opioid pain medications in the world, and people say, do we have that much more pain? And I don't know that we have more pain, but I guess we have the ability to try and ameliorate that pain, and these opioid analgesics seem to do it. So this is editorial on my part, and it's not all fact. But if you were to look up that YouTube video, it's very cool. It's not very long. It's called Addiction, and it'd be fun to watch. Another question: can you describe any alternative methods of pain management, other medications, etc.? So the Center for Disease Control website, there are a couple of simple approaches, but there's a very interesting Don Teeter does this presentation where he looks at studies involving ibuprofen and acetaminophen and compares it to IM morphine. And in the study, and if you guys want this, it's really cool. It's the National Safety Council, and it's Don Teeter. The slides, and I've used these in a number of presentations, show that actually the acetaminophen 500 milligrams and ibuprofen 200 milligrams is more effective in pain management than 10 milligrams of IM morphine. And there's a poll done of physician providers, and they're given a number of different options of what they would choose to use to manage pain. And 1% or less chose what was shown in this brief study to be the most effective. The vast majority, as we've been taught in medical school, identified morphine as the gold standard for pain management. That doesn't mean that there's not a role for opioid analgesics, but it does indicate that, the electricity went out here for a second. It does indicate that we may not be using all the information that we have in terms of pain management. Ice, heat, exercise, those are all great strategies for pain management. But some of the pain management specialists, like Jonathan Cost here at Hartford Healthcare, he talks about all kinds of other approaches as well. So there are some basic things that we can try, and then there are things that the pain management specialists can educate us on. But there are alternatives, and it's an eye-opening study that Cheater was highlighting. If there's any other questions, I can take them now. If you guys want any references, just let me know.
All right. If anyone has anything else, we're getting pretty close to time, so please share. And if not, I want to thank you, Dr. Allen, for this webinar. I found it really interesting personally.
Sure.
And I wanted to thank everybody else for attending today, and I hope you got something out of it. We will be sharing this to CCIP's LMS in the next few days, and hopefully we can find that YouTube video and share with all attendees as well.
Yeah, that would be great.
All right, and if anyone has any question that they're not trying to look through and type out right now, if you just press #6, you can unmute your line and chime in really quickly. All right, maybe not. Okay, so I think we're going to end this session for today. Once again, thanks, Dr. Allen, and I hope everybody has a good day.
Okay, thank you. I'll send you that video.
All right, thanks. Bye-bye.
Bye-bye.